All right, why don't you go ahead and start? Good morning, everyone. Welcome to Grand Rounds. We have three presenters this morning. Rachel Chen, Retina Fellow, will be starting. Thank you, Rachel.
Great. Welcome to Grand Rounds. I don't have any disclosures. This is a 20-year-old woman who presents for evaluation of bilateral optic disc edema. She reports that she has had progressive worsening frequency of headaches starting 3 to 4 months prior, but she attributed this to wearing an old pair of glasses. She was seen by an outside optometrist and subsequently referred to an outside retina office. That retina doctor obtained an MRI brain and orbits, which noted flattening of the globe and sinus disease and no masses, and then referred her to neuro-ophthalmology. Her review of systems is positive for starting a new estrogen medicine, which was prescribed by her endocrinologist, and otherwise negative for TBOs, blurred vision, pulsatile tinnitus, any focal neurological symptoms, diplopia, weight gain, or any other new drug use. Her past medical history is significant really only for Turner syndrome, for which she was taking the estrogen. On initial presentation, her visual acuity was decreased in the left eye to 20/30 plus pinhole. She had a trace APD and she had 8 out of 10 color plates. Her posterior exam, looking at the Optos photos, she has optic disc edema in the right eye with surrounding exudation, and then optic disc edema in the left eye with surrounding exudation as well, with significant sheathing and some punched out chororetinal scars. This is the fundus autofluorescence. You can see that there is some hyperautofluorescence associated with one of the chororetinal scars in the right eye, and in the left eye there is significant hyperautofluorescence associated with the subretinal fluid and exudation. The fluorescein angiogram of the right eye shows late disc as well as vascular leakage. In the left eye, this is an early, so some tortuous blood vessels, some blocking, and then a late showing disc leakage as well as vascular leakage and what appear to be aneurysms. Her OCT of the right eye shows some vitreous debris, an intact foveal contour, an ERM, and then nasally some retinal thickening associated with the disc edema. And in her left eye, the foveal cut looks like her contour is still intact. She still has vitreous debris. She has some retinal folds and ERM. And then as we scroll down, you can see the subretinal fluid associated with that hyperfluorescence, autofluorescence on the FAF and associated with the disc edema, as well as some abnormal retinal thickening here. Her visual field is poorly reliable, but you can see that her blind spots are enlarged, and in the left eye she has superior arcuate. And so the differential diagnosis for a young woman with Turner syndrome who has retinal vasculitis, aneurysms, and neuroretinitis. Conveniently, there is a syndrome called idiopathic retinal vasculitis, aneurysm, and neuroretinitis, or IRVAN. The differential diagnosis for this collection of signs on exam is very, very narrow. And so I've chosen to go over the differential for each separate part of this syndrome, which is much more broad. The differential for retinal vasculitis affecting mostly the arteries includes lupus, GPA, Behçet's, polyarteritis nodosa, Churg-Strauss syphilis, sarcoidosis. For neuroretinitis, we can think about Bartonella, TB, toxoplasmosis. And for a retinal arterial macroaneurysm, we can think about mostly ones that we see in hypertensive older individuals and the ones associated with Coats disease. But really, a patient who presents with all of these things would be highly suggestive of IRVAN. History of IRVAN. It was first described in 1973, likely by Carell et al. They actually published several cases of pediatric uveitis, and one of them was a 19-year-old woman who had retinal vasculitis and saccular aneurysms. In 1983, Kincaid published a second a few cases with the same signs that were reported. And initially, this was thought to be a self-limited disease, as 4 of the 5 initial cases reported in the literature had a benign clinical course with good final visual acuity. In 1995, Chen et al. Published a case series of 10 patients, and their results were actually quite different. The 10 patients were aged 9 to 44. They had a mild female predominance. They were frequently asymptomatic at time of presentation, and all of them had a complete systemic inflammatory workup, which was all negative. Based on the signs that they saw in this series of patients, they proposed 3 major criteria and 3 minor criteria, and actually coined the term IRVAN. The 3 major criteria are retinal vasculitis, very characteristic aneurysmal dilatations at mostly at arterial bifurcations, and neuroretinitis, as well as 3 minor criteria, which includes peripheral capillary non-perfusion, retinal neovascularization, and macular exudation, which we'll talk about a lot more later in this presentation. They followed up these patients for anywhere from 18 months to 104 months. 3 of the 10 patients were lost to follow-up. And in contrast to the previous studies in which all had, or 4 out of the 5 had a benign clinical course, out of the 7 patients that did have follow-up in this study, a full 4 patients, so over 50%, had progression of their disease with loss of vision, ending with a vision worse than 2160 on final follow-up. About 6 out of 10 of these had complications from vitreous hemorrhage, and 2 out of 10 of these patients, actually 2 out of 7 of these patients, because 3 were lost to follow-up, had neovascular glaucoma. And so fairly devastating visual prognosis for over 50% of these patients in this initial study. This is one of the figures from that Chen et al. Study. You can see that there are aneurysms here near the optic nerve head associated with exudation, same over here. Here there is an aneurysm, and it's much easier to see on the FA, and that tends to be the case. Here's another one here, that the aneurysms are much easier to identify on the fluorescein angiogram. This is another paper looking at imaging in IRVAN, which just shows some nice pictures. You can see over here that there's kind of like a knot-like coiled aneurysm at the bifurcation of arterioles. It shows up a little better and more clearly on the FA. And in a separate figure in a separate patient in this paper, you can see that this patient also has significant non-perfusion, a leaking macroaneurysm. Same over there as well. This paper also looked at ICG findings. The choroid is involved in this disease. However, it does not, the choroidal vessels don't develop aneurysms. They are dilated and they do leak on the ICG. I like to mention this specifically because this was actually a patient of Dr. Subramanian's. This is an interesting case of a 12-year-old girl who presented also for bilateral optic disc edema, actually underwent an LP and had an elevated opening pressure, and so was diagnosed with IH initially and then started on acetazolamide, which did not help with her optic disc edema, and so she had a fluorescein angiogram done that showed disc leakage, neovascularization, non-perfusion, and then here next to the arrow, a little bit of a arterial dilatation and aneurysm. And so she was diagnosed with IRVAN. There are typically no systemic associations with IRVAN, just like what was reported in the initial Chen et al. Study. However, over the years, there have been multiple single case reports of IRVAN-like disease in patients who did have something positive on their systemic workup. So this includes a TB positive patient from India, which is endemic for TB, as we all know. includes a patient who was positive for P-ANCA, a patient who was positive for antiphospholipid antibody, and a patient with a history of multiple sclerosis. But these tend to be more rare. On the whole, typically these tend to be young, healthy people, more likely to be females with no systemic association. The treatment for IRVAN is rather controversial, and it's aimed mostly at the two different important etiologies in this disease, which is inflammatory, but also neovascular. And so I'll talk about some of these things. This is a paper by Samuel et al., which is essentially a more detailed update on the patients that were covered in the Chang et al. Paper, and they also added an additional 12 patients. So in total, 44 eyes of 22 total patients. Based on the science they found in this study, they proposed a functional staging system for this disease. So stage 1 would be macular aneurysms, exudation, neuronitis, retinal vasculitis, all of the things that you would see in IRVAN without any sign of non-perfusion or neovascularization. Stage 2 is non-perfusion without neovascularization. Stage 3 is posterior segment neovascularization. Stage 4 is anterior segment neovascularization, and stage 5 is neovascular glaucoma. They looked at these patients, and based on their presenting stage, they looked at what their final visual acuity was. And as you can see, the later the stage, the worse your final visual acuity. What was more interesting was that they also looked at when these patients were treated with PRP in relation to their stage and in relation to their final visual acuity. And what they found was that all of the patients they treated early on when the patient was in stage 2, so non-perfusion but without neovascularization, all of these patients did really well. They didn't have any progression of at least the neovascular part of their disease, and they maintained good final visual acuity. Notably, they only have 3 patients in this group, so not a big sample, but interesting nonetheless. For the patients they treated in stage 3, so these are patients who have already shown some posterior neovascularization, possibly some vitreous hemorrhage, but not any anterior neovascularization. The majority of these patients did well, but a full 25% of them went on to progress and lose some vision. About 21% of these patients ended up having neovascularization of the iris, and 2 out of the 16 patients eventually went on to develop neovascular glaucoma. So the majority of them do well, but some of them do poorly. And obviously when we get to stage 4 and 5, despite having PRP, a full 50% of them had less than 2200 vision at their final follow-up. So from this study, they concluded that eyes with IRVAN who are treated early, preferably in stage 2, if not in stage 3, with PRP had better final visual acuity. Of course, we can't talk about treatment of neovascularization and treatment of macular edema in this age without talking about using anti-VEGF. And anti-VEGF, there have been multiple case reports in using anti-VEGF to treat neovascularization in conjunction with PRP in IRVAN. This particular study looked at a 50-year-old woman with stage 3 IRVAN who presented with stage 3 IRVAN with neovascularization in the right eye and vitreous hemorrhage in the left eye, who underwent Lucentis and PRP in the right eye and Lucentis and vitrectomy endolaser, an additional PRP in the left eye, and the authors report that the neovascularization resolved. Obviously, the effect of Lucentis should be a little confounded by the PRP and the vitrectomy that she got. This is another paper by Marin Lambias et al. Looking at using Lucentis to treat macular edema associated with IRVAN. On the left, you can see that on initial presentation, this patient had a lot of exudation, some aneurysms here, and macular edema on OCT, which after PRP and 2 rounds of Lucentis, lots of that exudation has improved, as evidence here on OCT as well. So anti-VEGF can be useful for macular edema. And going back to Dr. Subramanian's patient missed him so much that when he moved to Colorado, she did as well. Actually, that was just a coincidence, but she coincidentally did move to Colorado, and she was being treated by one of our retina doctors. When she presented, she already had a lot of PRP that was done. She had she had some leakage on FA, but no neovascularization. We had also done an OCTA as well, which you can see there's an enlarged FAZ, as well as some capillary remodeling around the FAZ. What we were treating her for mostly was her significant macular edema. She presented like 2 years before these OCTs were taken. I've just chosen at this time point because this is when we started treating her left eye. So amazingly, even with this amount of macular edema, her vision was 20/30 in the right eye, but it was 20/80 in the left eye. She has some ISOS loss in the left eye as well. And so this is from Dr. Olson's unpublished data, but we actually charted her macular thickness over the years with her treatment of anti-VEGF. And in the left eye, they initially started with Avastin. The first injection had a good effect, but the rest of them didn't really seem to have much of an effect on her macular thickness, despite getting every 4-week injection. So she got switched to Eylea, and there was a significantly improved effect, which later on with repeated injections seemed to have a more tachyphylactic effect in that repeated injections worked less and less well. And so Dr. Olson actually used what he called an Eylea bonus dose in purple, which means she got 0.06 cc's of Eylea instead of 0.05 cc's, which had a better effect later on. And so you can see from this data that anti-VEGF can be used to treat macular edema in IRVAN. Moving on to the inflammatory component, treatment with steroids for patients in IRVAN. In the initial studies of Chen et al. And then their update Samuel et al., they noted that although a lot of their patients got systemic steroids, it seemed to have no effect on the development of neovascularization later on. So these patients still ended up needing PRP despite getting oral steroids. However, steroids do seem to be useful in treating exudation. And you can see in this study with Sachi et al. In 2015, this patient presented with exudate that was more significant in the left eye compared to the right eye, also more significant on the OCT. And after treatment with azathioprine, PRP, and an Ozurdex, that edema is much better. So questionable benefit of oral steroid in terms of treatment for the neovascular component and preventing neovascularization, but useful for macular edema, as well as tamping down on the inflammation. For immunosuppression, it's kind of the same story. There's been a potpourri of single case reports where the authors report treatment of IRVAN with Cellcept, infliximab, methotrexate, cyclosporine, azathioprine. Common to all of these is that they really don't seem to have any effect on the development of retinal neovascularization, and those who develop that still need PRP and anti-VEGF, which is really a shame because vision loss in IRVAN is typically secondary to the neovascular sequelae, as well as the macular exudation. Early treatment is warranted if non-perfusion is seen, but some of these patients still appear to progress despite aggressive treatment with PRP, anti-VEGF, and vitrectomy. So looking back at our patient, we looked a little closer, and initially we had thought that this was IRVAN. But looking at the fluorescein again, we really question, is this really IRVAN? Because, you know, you all know lots about IRVAN now, but IRVAN, the aneurysms tend to be associated with the arteries. And in this fluorescein angiogram, what we thought initially were aneurysms are all mostly associated with the veins. And some of these that looked adjacent to the arteries are actually staining from the chorioretinal scars that she had on exam. So looking back at this patient, we actually no longer think she has IRVAN. Instead, she has a retinal vasculitis. And looking back at the literature as well, retinal vasculitis has not been associated with Turner syndrome, and Crohn's disease tends to have an arteritis instead of a vasculitis as well. So we think this is actually an idiopathic retinal vasculitis instead of IRVAN. Looking at her clinical course, after her initial presentation, she disappeared for about almost a year and a half. She represents after seeing an optometrist who noted further decreased vision in the left eye. She's now 2250 in the left eye from 2030 on initial presentation, and she has a 3+ APD. Her right eye, she has a little bit more sheathing. She has this subretinal fibrotic appearing area nasal to the nerve. And looking at her left eye, there's really been a big change. So she still has that disc edema. She still has more exudation. She still has this sheathing, but she's developed this subretinal fibrosis temporal to, in the temporal macula really, as well as some intraretinal hemorrhages. FA of her right eye shows increased disc leakage and vascular leakage. And of the left eye, you can see that there's some non-perfusion over on the temporal periphery. There's really a lot more vascular leakage as well as nerve leakage as well. Her OCT in the right eye remains mostly the same, as most of the changes are nasal to the nerve. She still has a good foveal contour, which is probably why she's seeing 20/25. But in her left eye, there's been a significant change. The foveal contour is no longer intact. She has some traction from that area temporal to the macula. She has a disorganized retina with loss of the outer retina. She has intraretinal fluid that's adjacent to that area of subretinal fibrosis. Her visual field is still not very reliable, but does appear to have progressed as well. And so for her, because she had so much inflammation on exam and especially on the fluorescein angiogram, she was started on treatment with a systemic prednisone with the goal to transition to immunosuppression. She did undergo an autoimmune workup, which is negative except for a high CRP of kind of unknown significance. 2 weeks after that, she came back, and already her intraretinal fluid was significantly improved on just the oral prednisone alone. She received bilateral Ozurdex at this visit to try and help with the transition to immunosuppression. She was started on Cellcept, and then her prednisone was tapered. 2 months later on follow-up, her prednisone had been tapered to 10 milligrams. Her Cellcept was up at 1,000 milligrams BID, and her vision was stable. She was much more quiet on exam and much more quiet on the FA compared to her representation. She wasn't able to tolerate the Cellcept, and so she was transitioned to Myfortic, which is basically a kind of like a different formulation for Cellcept that was easier on the GI system. 2 months after that, she came back. She was fairly stable. She had a little bit more leakage on her FA, but at an acceptable level, and her exam was quiet. So her prednisone was further decreased, and her immunosuppression was further increased. And this is her 3 months after that, lower dose of prednisone, higher dose of Myfortic. She remains quiet. She still has persistent leakage on the FA, but acceptable for now. 3 months after that, she comes back and she has now been off of prednisone and Myfortic for 2 weeks, self-discontinued because she's had still significant GI issues. And in fact, she's lost 80 pounds in the interim. Her vision is now count fingers. She has more inflammation in both eyes, and she has new vitreous hemorrhage in the left eye. On the fluorescein angiogram, we weren't able to identify any focal areas of neovascularization, although there's a lot of blockage from the vitreous hemorrhage, so it could be hidden under that. At this visit, she got an Avastin and an Ozurdex and was told to restart her oral medications, and she was seeing a gastroenterologist. On follow-up in the interim, she's been diagnosed with Crohn's disease. She's back on the systemic medications, and she looks much more quiet on the on exam. Her vision's a little bit better. She still has vitreous hemorrhage, and so she got another Avastin at this point. Still, the FA didn't really show many areas of malperfusion or neovascularization.
It's okay. It's mommy's meeting.
3 months later, coming back, she was looking better. That vitreous hemorrhage had mostly resolved. She was still quiet on exam, and so we deferred further intraocular treatment at this time. But when she comes back, she again has a recurrent vitreous hemorrhage on this current treatment. And so at this point, we decide to do an Avastin and sign her up for vitrectomy. So that's really fairly close to when we last saw her. So she was actually a case of very difficult to treat retinal vasculitis that we initially thought masqueraded as IRVAN, but actually isn't IRVAN on further examination. So in conclusion, looking at IRVAN, IRVAN is a rare inflammatory condition. It is very characteristic when you see a combination of retinal vasculitis, macroaneurysms that affect the arteries, and neuroretinitis in a young, otherwise healthy patient. The vision loss in IRVAN is due to macular edema and neovascular sequelae and can be visually devastating. And so early PRP in combination with possibly anti-VEGF is recommended to decrease that risk of vision loss due to neovascularization. References, thank you very much. I'll take any questions.
All right, thanks. Any questions from the audience? So Rachel,
so interesting.
You recommend keeping this in, oh, go ahead, Paula, sorry, go ahead.
What's interesting about IRVAN is how sometimes the aneurysmal dilatations, unlike retinal macroaneurysm, can resolve with inflammatory treatment. And so also what's interesting about IRVAN is that the neovascularization component does not always respond to PRP or treatment with steroids, unlike other inflammatory conditions. So sometimes when there's neovascularization, you think of in neovascularization associated with diabetes will always respond to PRP and anti-VEGF, but the NV that's associated with inflammation in other conditions can respond to control of the inflammation, but not always the case with IRVAN. Prem, what were you going to say?
No. I was going to ask just, you know, when patients come in with a suspicion for IRVAN like this, and, you know, Rachel, you know, as you said, over time, you found that this was more of a, let's say, idiopathic retinal vasculitis, but didn't fit into that IRVAN category. Was it just the venous nature of the aneurysms? Was there something else? Was there more inflammation in the vitreous, something that pointed you away from the IRVAN diagnosis ultimately? Or was it primarily the vascular stuff not fitting?
It was primarily the vascular stuff, and actually the areas that we initially thought were aneurysms, when we looked back, one, they were mostly next to the veins, but they were actually more consistent with like staining from all of those punched out choroidal scars that she had. They just looked like aneurysms because most of those were perivascular, and on the FA, you know, it was difficult to tell on initial review. In IRVAN, you definitely can have vitritis, and so her amount of vitritis didn't really steer us away or toward that that diagnosis.
Thanks. Any other comments, questions? Okay, well, thank you, Rachel. Why don't we move on to Lucy, who is our next presenter.
There we go. All right, thank you everyone. So huge thanks to Dr. Chalier and Dr. Hing for helping with this case and this presentation. So this is a 38-year-old male with a recent diagnosis of cryptococcal meningitis referred to clinic at Denver Health to evaluate for papilledema and double vision. History of presenting illness, he reports headaches and double vision for the last 8 weeks since he was diagnosed with cryptococcal meningitis. His left eye won't turn out. He reports binocular horizontal diplopia. He denies decreased vision, flashes, floaters, or eye trauma. He's HIV negative, but does have a history of IV drug use. His past medical history is significant for Cryptococcus gattii meningitis, which was initially diagnosed during admission at Swedish Hospital at the end of August. He was transferred then to Denver Health for neurology and ID input in September and was discharged from there to an acute rehab facility. He was referred to the eye clinic on discharge and wasn't seen in the eye clinic until the beginning of November of last year. He has a history of substance abuse and comorbid mood disorders, and since he was diagnosed with meningitis, he's been living with his mother. His base eye exam, notable for slightly decreased vision in both eyes, improved a little bit with refraction, normal IRP, and normal pupils. This was his motility exam. Please ignore the subcondylartheme and the lid incisions. These photos were taken later in his treatment course, but his motility exam remained the same throughout. So you can see he's got a -4 abduction deficit of his left eye. He had a normal anterior segment on slit lamp exam. And then on fundus exam, there was 360 degrees bilateral disc swelling, some obscuration of the vessels, and then some disc hemes. Our assessment and plan at that time was grade 4 papilledema with a left cranial nerve 6 palsy. We were concerned for raised intracranial pressure in the setting of recent meningitis. We had an urgent discussion with his ID and neurology team who planned to get him in right away for repeat imaging and lumbar puncture. We also tried foiling and stick-on prisms for the diplopia, but he did not like using these at all. However, before he can get the repeat imaging and lumbar puncture, he gets admitted at Swedish again with altered mental status after a drug overdose. He has a lumbar puncture for this presentation, which is notable for an elevated opening pressure to 38 centimeters of water, a few lymphocytes, slightly decreased glucose, elevated protein, a persistently positive cryptococcal antigen, but fungal culture is negative. He stays for 1 week receiving IV antifungals, again for Cryptococcus, but then he leaves AMA. He returns to the eye clinic 3 weeks later. At this point, his vision's a little worse in his right eye from 2040 to 2050 and significantly worse in the left eye from 2050 to 2400. His papilledema is also significantly worse, as can be seen in these photos. And I would ask, could one of the residents describe what they see for us in these images?
One of the first years describe the photos.
Yeah, I can. This is Becca. So there's kind of loss of all of the anatomic marker, regions of the disc. So there's 360 disc edema with RNFL hemorrhages. I can't really make out any vessels in the right eye, maybe a little bit in the left, but so pretty significant vessel obscuration. There's pre-retinal blood in the right eye, it looks like, as well. Those are kind of the main things I see.
Yeah, really good. Thank you. So assessment and plan at that visit, now grade 5 papilledema, unchanged left 6 nerve palsy. I again had an urgent discussion with his ID doctor who kindly arranged for an urgent admission for therapeutic lumbar puncture, ongoing IV antifungals, and then evaluation for possible VP shunt versus lumbar drain. During this admission at Denver Health, he had a repeat lumbar puncture, still with significantly elevated opening pressure, this time with more white blood cells, still predominantly lymphocytes as would be expected. ID were concerned for recurrence given this lumbar puncture, and his cryptococcal antigen titer also increased. So they adjusted his antifungal therapy. He also gets started on oral steroids in an attempt to help with swelling, and he has an MRI. Could one of the residents talk us through the image on the left-hand side of the screen?
The second years, volunteer, or I'll volunteer one of you. All right, Austin, go for it.
Maybe looking at the globes first, maybe it looks like there's some flattening of the posterior globe. And maybe the ventricles, it's hard to tell, but maybe the ventricles are kind of slit-like and thin. That's really all I can tell. Maybe you can see the optic nerve edema too in the globe.
Yeah, so there's pretty significant swelling of the optic nerves, definitely flattening of the posterior globe. Maybe not as obvious here, but there is some optic nerve sheath distension. And then looking at the image on the right, he has the empty cell sign. So all consistent with raised ICP. During this admission, he's evaluated by neurosurgery who say that he's not a candidate for VP shunt. We push for lumbar drain, but the teams are reluctant to do this given his history of leaving AMA. And then as a self-fulfilling prophecy, one night his mother and the nursing staff have a conflict and he actually does leave AMA. I called his mother the next day when I found out that he left AMA, but she was adamant that he's not coming back to hospital. She did say that she promises to bring him to any outpatient appointments. At this point, I called Dr. Charlier to discuss possible options such as optic nerve sheath fenestration. The oculoplastic team strongly recommended that he get readmitted and consider a lumbar puncture drain. However, failing that, they were willing to try a fenestration and requested a pre-op visual field and OCT. So with some coaching by his mother, remember this is a patient with poor coping skills to begin with, who's now facing medical challenges that would be difficult for anyone. He agrees to fenestration and comes to clinic for his pre-op visual fields and OCTs. The visual field is shown here. You can see it's pretty poor reliability, but you get the idea that he has significant abnormality in his visual field. His visual acuity at this appointment was 2100 in both eyes. And this was the attempt of the OCT to capture the optic nerve and ganglion cell. On December 30, 2019, he undergoes bilateral optic nerve sheath fenestration. He has a large volume LP on the morning prior to surgery. The opening pressure was 47 and the closing pressure was 7 to 9. These are some images from the medial lid crease approach to optic nerve fenestration from a different case of Dr. Charlier. So as a reminder, these were his pre-op optic nerves and visual acuity was 2100 in both eyes. And then on post-op day 4, his acuity improved slightly to 2080 in the right, 2060 in the left. There's still papilledema, but there are some signs of improvement. So some background about Cryptococcus. It's a genus of fungi within the order of Tremolales. Like many fungi, it grows in rotting wood and soil. Cryptococcus is also found to grow readily in bird feces. It's sometimes called the jelly fungi due to these gelatinous fruiting bodies, like you can see here. There are over 30 species of Cryptococcus. The two that are particularly relevant are C. gattii, which is overall more rare, but occurs in immunocompetent hosts more than Cryptococcus neoformans. These images show Cryptococcus under 4 different stains. On the top left is the GMS or the Gamori methenamine silver stain, but it can also be seen on the saccharomine stain, the PAS stain, and the gram stain, like I've shown here. The other well-known stain for Cryptococcus is India ink, which I show here on the right. Cryptococcus has a thickened polysaccharide capsule, which allows it to evade macrophages, but also makes it easily stained by India ink. It's typically thought of as a subacute meningeal encephalitis. The organism is usually acquired by inhalation and becomes latent infection in the lymph nodes of the lungs, and then disseminates. It can disseminate to almost any tissue, but it has a strong predilection for the central nervous system. Some of its neurotrophic factors include a specific matrix metalloproteinase and urease, which allow it to penetrate the blood-brain barrier. It also has a dopamine-utilizing blockase, which helps it to survive in CNS. This study from 2013 estimated the incidence of cryptococcal meningitis. They used data from the Agency for Healthcare and Research Quality. 18 states had continuous reporting over the 13-year period, and the authors estimated this represented about 53% of the US population. During this time period, there were 13 hospitalizations for cryptococcal meningitis. 21% were HIV negative. Interestingly, the cost was slightly but significantly higher for patients with cryptococcal meningitis who were HIV negative. And these maps show the geographic incidence for the 18 states with continuous reporting of cryptococcal meningitis over the 13-year period. On the left is the incidence for HIV positive, and on the right is the incidence for HIV negative. In Colorado, you can see the incidence was below 2 hospitalizations per million population in both subgroups during the 13-year population. And then still from the same study, these graphs show the trend over time for hospitalizations and mortality for cryptococcal meningitis. On the left is hospitalizations, and then on the right is hospital mortality. Both have been slowly declining for HIV positive individuals, but there's a fairly steady rate for HIV negative. A study by a group from the University of Alabama in Birmingham in 2001 collected data from 15 hospitals in the US between 1990 and 1996. They reported 306 HIV negative patients with any type of cryptococcal infection. Half had CNS involvement, a quarter had received steroid therapy, another 24% had underlying chronic liver, kidney, or lung disease. 16% had underlying malignancy, and 15% had a history of a solid organ transplant. In this study, mortality from cryptococcus was 12%, and the risk factors were age greater than 60, hematologic malignancy, and organ failure. Another study from the same group in 2013 looked at 90-day mortality among HIV negative and immune competent patients. They found the mortality was higher for those who were HIV negative, 29% versus 20% for HIV positive. Some theories for why HIV negative patients with cryptococcal meningitis have a poor mortality is a possible delay in diagnosis. It's not often high on the differential for immune competent patients, and a possible immune response to cryptococcus. They also note that C. gattii, which more commonly affects immune-competent patients, tends to cause more granulomatosis lesions in the lungs and brain, and these patients seem to have more neurological sequelae. The C. gattii species is known to be endemic to the tropics, particularly Australasia and South America. However, since 1999, when there was an outbreak of C. gattii meningitis among immunocompetent patients in the Pacific Northwest, there's been a steady number of cases in the US. Cryptococcal meningitis typically presents subacutely with headache, sometimes altered mental status, fever, nausea, vomiting. The mean duration of symptoms to presentation is typically longer in patients who are HIV negative, and diplopia and decreased vision is some of the common eye symptoms. So this study from 2012 looked at 90 patients with cryptococcal meningitis. All were HIV positive. 18% had a best corrected visual acuity less than 2200. 47 patients in the study underwent visual field testing, of which 70% had an abnormal visual field. I'm sure there's some selection bias here in that those who underwent a formal visual field probably were more likely to have a defect. But these are some of the defects that they noted in their study. A study from Papua New Guinea in 1997 reported on 82 immunocompetent patients with C. gattii meningitis. Half of the patients had vision loss at some point in their course of disease. The risk factors for vision loss were presence of a 6-nerve palsy and a high cryptococcal antigen titer. They also noted that vision deteriorated in 17% despite appropriate antifungal therapy, and in 3%, even once they had completed their course of antifungal therapy, there was subsequent vision loss. The authors hypothesized that there was some immune-related damage to the optic nerves beyond the compressive damage from raised ICP, but there was no data presented to support this. The VCSC also lists some other findings in cryptococcal infections, including retinal choroiditis, cotton wool spots, homonymous visual field defects, and nystagmus. And these photos here are taken from a case report of bilateral exudative retinal detachments associated with cryptococcal infection. Without treatment, Cryptococcus meningitis is usually fatal, and as I mentioned early, C. gattii tends to create more of an inflammatory response and often causes hydrocephalus. In HIV-negative individuals, altered mental status and fungal burden seems to be important prognostic factors. Previously, the mainstay of diagnosis for cryptococcal meningitis was the India ink stain, which I showed earlier. Then there was the latex agglutination test, which detected the cryptococcal capsular polysaccharide. Now we have the lateral flow assay. It has multiple generations and is extremely sensitive to cryptococcal antigen detection. It can also detect antigen in other bodily fluids, even a finger prick sample, which is helpful in low resource settings. The antigen test may stay positive for months, so if there is concern for reinfection during this time, a fungal culture is needed. This table shows the performance of the lateral flow assay compared to fungal culture. You can see that it's highly sensitive and highly specific in both serum and CSF. The treatment for Cryptococcus follows a three-step induction, consolidation, and maintenance approach. You can see that the entire course is extremely long. The induction period is 4 to 6 weeks for HIV-negative patients with Cryptococcus gattii. This was part of the concern with our patient in that he never fully completed the induction in one period, as he had elevated LFTs during his first admission and then left AMA during the second. Later, during the consolidation and maintenance periods, there was concern about efficacy as his culture came back with a high MIC to fluconazole. It's not uncommon for C. gattii, but that's why they decided to switch him to isofluconazole, as I showed earlier in the earlier slide. In addition to antifungals, these patients need urgent management of their raised intracranial pressure, which is common, particularly in HIV-negative patients, thought to be due to either central obstruction of the fourth ventricle or an arachnoiditis with communicating hydrocephalus. Therapeutic lumbar punctures are often performed in these patients, usually taking up to 30 mils of CSF at a time. This is a case report from 2005 of HIV-associated cryptococcal meningitis. A patient was transferred to a hospital in London, UK. On the top of the chart, you can see the visual acuity, baseline 6/9, which is about 20/30. It deteriorated to 6/60 or 2200 around day 15, which is when they started serial lumbar punctures. And the lumbar punctures are shown as the down arrows in chart A. They removed about 20 mils of fluid a day, but the CSF persistently reaccumulated quickly and the opening pressures continued to remain high, and the vision deteriorated to count fingers. So they placed a lumbar drain, which was left in place for about 10 days, and when the drain was removed, the visual acuity was back to the baseline of about 20/30. And chart B shows the amount of fluid that was drained each day with the lumbar drain. Another option for management of raised ICP is shunting. This was a case series of 10 patients with HIV-negative cryptococcal meningitis and hydrocephalus. All had induction with IV amphotericin B and or oral flucytosine. 9 patients had improvement in their neurological symptoms after shunting. One of the patients who did not improve, the authors noted, had extensive cerebrovascular disease from prior strokes. And it's important to note that 5 of them had evidence of a non-functioning or slowed flow through their shunt, and 3 shunts needed to be revised, one of them multiple times. Steroids are often tried to reduce edema, but there's no good evidence really supporting their use in cryptococcal meningitis. This is a study again from Papua New Guinea in 16 patients with HIV-negative C. gattii meningitis who received steroids. The main steroid that they received was hydrocortisone IV for the duration of their stay. All 16 were also treated with IV amphotericin and flucytosine. 11 had optic disc swelling on admission. 4 had vision loss on admission, of which 3 improved. 1 deteriorated despite steroids, and 1 patient without vision loss on admission had a deterioration despite steroids. This is a case report of a 15-year-old female with lupus and cryptococcal meningitis who developed severe vision loss over 6 days, to the point of no light perception in her right eye. She was managed with acetazolamide, dexamethasone, and repeated LPs. Fortunately, in this case, she had return of excellent vision, and this was maintained at 1 month, though they did note there was some pallor of the right optic disc. Optic nerve sheath penetration has been reported in the literature as early as 1872. And remember, this time there was no anesthesia, which is slightly horrifying. Fortunately, now it's considered a safe and minimally invasive procedure with low complication rate. Though there are no studies of the complication rate of optic nerve sheath penetration in cryptococcal meningitis. There are multiple approaches to accessing the jewel sheath. Most of our surgeons here perform it via the medial transconjunctival approach or via the transcutaneous via superior medial lid crease. There are a few case reports of optic nerve sheath penetration for cryptococcal meningitis. All of them are in HIV positive patients, and the majority are from the early to mid 1990s. This one, although from 2008, did report reasonable improvement in visual acuity after bilateral optic nerve sheath penetration. It's important to note that they collected a specimen intra-op, which did show infiltration of the sheath by cryptococci. However, there were no signs of orbital infection over their limited length of follow-up. And this paper from the early 1990s, in the pre-HOT era, they also reported some improvement in visual acuity after optic nerve sheath penetration in 2 patients. Sadly, both patients were deceased within 21 and 22 months respectively. However, they said there was no post-op infections over that time period. One patient did have an autopsy and was found to have patent gerotomies. So back to our patient. He still has raised intracranial pressure and slowly deteriorating visual acuity, despite not having evidence of an ongoing infection and open gerotomies. We suspect now this is related to fibrotic changes in the meninges, reducing CSF compliance and creating a permanent ICP problem. His cryptococcal antigens have been persistently high, but there's been no growth on culture since August of 2019. He had another admission for IV antifungals in consideration of a drain, which was again deferred. These were his visual fields on post-op month 2. And then his optic nerves on post-op month 3, definitely improving. After a lot of arm twisting by the infectious disease team in Lacey, neurosurgery finally placed the VP shunt this past Monday for vision preservation. Our goal for him is to be independent in activities of daily living. We did discuss a low vision rehabilitation referral, which they're considering, and he actually has an appointment today at Denver Health. So in summary, C. gattii, it's a rare cause of infectious meningitis. Raised ICP is common in these patients and can lead to significant visual morbidity. Ophthalmology should be involved and evaluate early on. There is no clear benefit to any one therapy for raising intracranial pressure in cryptococcal meningitis, but optic nerve sheath penetration can be performed safely and does not have to be a last resort. Thank you. Any questions?
Thanks, Lucy. Nice job.
I'll just make a comment that I think you did the right thing by going ahead and fenestrating him. There's always this concern you're going to spread infection to the orbit. There are these rare, small reports in the literature that support the idea of doing it. And I think the problem, as Lucy pointed out, is that long-term, this problem doesn't go away. Because of scarring in the meninges and decreased CSF compliance, you are still likely to have to deal with elevated intracranial pressure on an ongoing basis.
All right, thank you.
All right, thank you, Lucy. Let's go ahead and Amit, if you'd like to go ahead and start your presentation, please.
Great. Cool. All right, thanks everybody. I'll go ahead and get started. So in my case, I have a 41-year-old female. She presents with 2 months of bilateral vision loss, presents to the Denver Health Eye Clinic about a year ago. Let's see, there we go. She had pain and vision loss starting in her left eye. in January, and then followed by the right eye about 2 months later, a similar course. She was admitted at an outside hospital in March for this vision loss. She had a pretty extensive workup, including a CTA head and neck showing mild lymphadenopathy. MRI brain and orbits were unremarkable. ESR and CRP were normal. HIV was negative. She was seen by an ophthalmologist while she was admitted. He noted bilateral ischemic retinopathy and then an asymmetric cataract and recommended outpatient follow-up. Some additional history, medical history is significant for bipolar disorder and diabetes. Her ocular history, she reported having a lazy eye in the left eye as a child. And then her social history, she was homeless at the time that we saw her. She had a history of meth use, although she denied any history of IV drug use, and then denied any drug use over the last approximately 6 months. So on our initial exam, our visual acuity was count fingers at 1 foot in the right eye, light perception only in the left eye. Her pressure was normal in both eyes. Pupils were irregular and sluggish, difficult to assess for an APD on our exam. This was the slit lamp and fundus exam. I will say it was a very difficult exam. She was like really hysterical throughout the entire exam. It was very difficult to calm down, very difficult for her to stay still. But what we noticed significantly in the right eye, she had inferior KPs, 3+ anterior chamber cell with some posterior synechiae, and then vitritis. And then on the retinal exam, it's described as inferior retinal versus posterior vitreous whitening. On future exams, it seemed more consistent with vitreous condensation rather than true retinal whitening. And then on the left eye, the exam was more consistent with prior uveitis. So she had some inactive appearing KPs on the cornea. Anterior chamber was quiet, but had 360 posterior synechiae, and then very dense vitreous condensation. So in summary, you have this 42-year-old homeless female, history of drug use, presenting with sequential painful vision loss over the course of about 2 months. Exam shows active panuveitis in the right eye and evidence of prior panuveitis in the left eye, and then prior neuroimaging was unremarkable. So any of the residents want to go through a differential for this?
Yeah.
Infectious, oh, sorry, go ahead.
Yeah, I was just saying what you were saying. Starting with infectious, for panuveitis, you can think of things like syphilis, of course, tuberculosis. You can have viral, like ARN, and then as far as inflammatory, you can think of things like sarcoid, VKH. I know there's more they're thinking about the time. But, yeah, so just like I guess categorizing it into infectious and inflammatory.
Yeah, I think that's a great way to kind of categorize things. So we had so infectious, inflammatory, neoplastic. Infectious, we also had endogenous endophthalmitis, especially given her history of drug use, like a viral retinitis or ARN picture, syphilis, toxo, TB. Inflammatory things would, sarcoid, VKH, Behçet's, and then neoplastic less likely given her age, but you can also consider things like leukemia and lymphoma. So given her concern initially for endophthalmitis, especially fungal with the history of drug use, we did a tap and inject on her right eye with injecting vancomycin, ceftazidime, and voriconazole. And then in the left eye, we also injected voriconazole as well. We started her on some topical steroids and cycloplegics for the posterior synechiae. And then the plan was to get a workup, including syphilis antibodies, an ACE and chest x-ray for sarcoidosis, and then a quantiferon gold for tuberculosis. We instructed the patient then to follow up the next day after getting the labs done. Unfortunately, she did not show up for another week, did not get her lab work done. She said she had been using the drops for about 4 days at that point. The exam overall was stable. It's still really significant inflammation in the right eye. We were able to get an OCT of the left eye at this time. Here's one slice through the macula. You can see really significant retinal nerve fiber layer swelling, edema. And then in the outer retina, it's really hard to make out any visible structures. So the ellipsoid zone is really not visible. Looks pretty atrophic and disorganized. So given their difficulties with our exams in the clinic, and then the need for this urgent workup, we admitted the patient to the inpatient side with plans for an exam under anesthesia the next day. On the morning that we were going to do the exam under anesthesia, her syphilis testing came back positive. So you can see the syphilis EIA screen was positive, along with the FTA ABS and then an RPR titer. And I'm going to go over the different testing. But so we diagnosed this patient with ocular syphilis. So I'm going to go a little more detail about syphilis and ocular syphilis. So syphilis is a chronic multisystem bacterial infection. There's a lot of mention in just kind of in historical medicine records. So initially described in Europe in the 1400s. The causative organism Treponema pallidum was not identified though until the early 1900s. Treponema pallidum is very difficult to grow in vitro, which makes it difficult to do any really significant research on it. Humans are the only natural host, and it's a 0.2 micron diameter spirochete. Rates of syphilis hit a nadir, at least in the United States, around the year 2000, but have since been climbing steadily, especially in the western parts of the United States. So these are rates per 100,000 from the CDC in 2017. You can see from about 2008 to 2017, the rates have more than doubled for syphilis. Rates are particularly high in the population of men who have sex with men. So you can see that in this chart. They make up the majority of infections, although rates in other men and then also in women are rising pretty rapidly as well. So just for the sake of time, I'm not going to go into congenital syphilis, but I'll talk about acquired syphilis. So in general, it's acquired by direct contact, usually sexual, with active primary or secondary lesions. So this is kind of a chart of how syphilis, the stages of syphilis progress. So you're infected and then you get primary syphilis, secondary syphilis, and then latent. And then a certain percentage of patients with latent syphilis will progress to tertiary syphilis. So going into a little more detail about these stages. So primary syphilis is characterized by a single chancre at the site of inoculation, along with regional lymphadenopathy. The chancre develops on average about 3 weeks after inoculation, and then will heal spontaneously in about 4 to 6 weeks. So it's possible that it goes unnoticed, as generally these are painless and only last for a few weeks. So after primary syphilis, and we have secondary syphilis. This usually will manifest about 3 months after infection. You have non-specific systemic symptoms, malaise, weight loss, myalgias, and then the more specific things is especially the disseminated rash. So initially on the trunk and the extremities, and then we'll progress to the palms and soles, and then also more generalized lymphadenopathy. So here's some pictures of the mucocutaneous rash that you can get. The one on the left is more over the chest and the trunk, and then you can see the palmar rash there. So we'll raise your suspicion for syphilis if you see this kind of rash. Latent syphilis. So after secondary syphilis, those symptoms will usually resolve in about 3 months. And then latent is divided in between early and late. So early is the first year after infection. During that first year, about a quarter of patients will have recurrent manifestations of their secondary syphilis symptoms. And then late is greater than 1 year after infection. Fortunately, at this stage, you're considered mostly to be not contagious, or sexual transmission at that point is very unlikely. And then once latent syphilis, and once you get to that late stage, it generally will end with either antibiotic therapy or the development of tertiary syphilis. So like that flow chart showed before, 28% of latent syphilis will progress to tertiary syphilis. They're characterized by a few different things. So gummas are these granulomatous nodular lesions. They can be on the skin, bones, internal organs as well. You get cardiovascular manifestations. Most severe of these is aortitis. That could lead to things like aortic regurgitation and even aortic dissection. And then neurological includes things like tabies dorsalis and classic kind of Argyll-Robertson pupil, which is really only seen in the very late stages. Tabies dorsalis occurs because of demyelination of the dorsal columns in the spinal cord, so you can get problems with proprioception, vibration sensation, and other things like that. Just a clarification here that Neurosyphilis is kind of a separate entity that can occur in either the secondary or the tertiary stages. Discussing now ocular syphilis. So the literature seems to show around 5 to 10% of new syphilis cases will have evidence of ocular involvement. It's considered a type of neurosyphilis, although it's not always associated with abnormal findings on a lumbar puncture or with specific neurological symptoms. And the important thing to keep in mind with ocular syphilis is that it can really affect any part of the eye with really a very, very broad spectrum of signs, symptoms. One of the reasons why it has this historical nickname is the Great Masquerader. So this is a table from the AAO, and the point of this is just to show, again, it's really can involve any part of the eye in the orbit and present with any kind of symptom. So really any inflammation in and around the eye, syphilis should be on the differential or something that you should at least think about. One of the interesting manifestations of ocular syphilis I just wanted to talk about briefly is this posterior placoid chorioretinitis. So you classically will get these placoid lesions at the level of the RPE, normally in the macula or the posterior pole. So here's some good photos in a paper from 2017. So the top photos, you can see these yellow kind of elevated placoid lesions through the macula in both eyes. And the bottom photos showing the OCTs, you get a loss of the ellipsoid zone there in the outer retina, and then you can see these kind of nodular elevations in the RPE in both eyes, and those are thought to be the placoid lesions that you see on exam. So these were the initial photos in this paper, and then 1 month after treatment, you can see that the yellow placoid lesions on the photos have pretty much resolved. On the OCT, also those RPE elevations seem to be gone, but you still have some kind of patchy attenuation or loss of the ellipsoid zone on the OCT there in both eyes. So going into syphilis testing, so if you're suspicious for syphilis in a patient, what test do you get? So there's two categories of tests. There's the treponemal test and the non-treponemal test. So the treponemal test detect antibodies specifically to T pallidum proteins. The non-treponemal tests, which include things like RPR and VDRL, detect antibodies generally against cardiolipin, which is released from cells damaged by syphilis. So it's not as specific to syphilis. So with this reverse algorithm, the first test you get is a treponemal test. In this example, they get the EIA test. If that one is negative, then you're pretty much done. You can be confident that they do not have syphilis. If it's positive, then you get a confirmatory test with a non-treponemal. Here they get an RPR. If that one is also positive, then again, you can be confident that they do have syphilis. If it's negative, then you want to get a second treponemal test, one that is different than the initial one you get. The interesting things about the non-treponemal test is it can be used to follow treatment response. So it tends to decrease or will become non-reactive after treatment. And then it can also become non-reactive just with time. So if you get a positive, if you get two positive treponemal tests but a negative non-treponemal, it could be because they had syphilis in the past and were treated, or occasionally they could have very latent syphilis where the RPR has become negative. If your second treponemal test is negative, then syphilis is unlikely. You can consider this first positive treponemal test to be a false positive. Some people in that situation would recommend repeating a test a few weeks or months down the line, but unlikely to have syphilis in that case. So lumbar puncture. So lumbar puncture is warranted in patients with clinical signs of neurosyphilis, and that includes ocular syphilis. They mainly get it, you want to evaluate the CSF cell and protein counts, and then you can also obtain a CSF VDRL. Like most of these non-treponemal tests, they're high specificity but low sensitivity. It's in ocular syphilis cases, it's positive in about 60% of cases. The useful thing about this is the titers can be used to monitor treatment response. So in some patients that we've had, neurology will repeat the lumbar puncture about 6 months after treatment has been done to verify that the VDRL has become non-reactive. Treatment for syphilis, from our standpoint, it's pretty simple in that the treatment is penicillin. For primary, secondary, latent, tertiary syphilis, it's different doses of intramuscular penicillin. For neurosyphilis, the preferred treatment is to use IV penicillin over a 2-week course. We do have alternative treatments here listed, but if someone has a true penicillin allergy, the recommendation is that they are desensitized to penicillin as a first line, rather than use some of these alternate therapies like doxycycline. Quick discussion about steroids. So there's not a lot of evidence in the literature or guidelines on the timing and utility of steroids. There's been case series where there's been some patients treated with steroids and some patients that haven't. Doesn't seem to be a big difference in outcomes. There are some people who feel like there'd be a benefit in treating people with steroids to help prevent what's known as the Jerisch-Herxheimer reaction. So this is as a reaction you get as the syphilis bacterium are getting killed. They release They can release endotoxin into the blood, and that can result in kind of like a sepsis type picture. So there's some people who feel like starting steroids concurrently or soon after starting antibiotic therapy can be helpful in preventing this reaction. In terms of ocular steroids, again, there's not a whole lot of evidence in the literature for plus or minus. I think most people would start some topical steroids along with cycloplegics to help with in the situations where you have an anterior uveitis to help prevent posterior synechia. But again, not much literature to say one way or the other. So back to our patient. So she had already been admitted. She had a lumbar puncture done after the syphilis testing had come back positive. It did show some elevated white blood cells, but the VDRL was negative. She was admitted for 2 weeks, received IV penicillin 24 million units daily for those 2 weeks as the recommendations. We did see her on day 14 of that penicillin treatment just prior to discharge. Her inflammation had significantly improved, but unfortunately, her vision remained hand motion in the right eye, light perception in the left eye. And she has been lost to follow-up since, unfortunately. So I have one more case that coincidentally I saw the exact same week that this patient had shown up. So this is a 26-year-old male who was sent to Denver Health ED from a Vail for concern for optic neuritis. He had 5 days of floaters in the right eye, was really his only symptom. On exam, his visual acuity was 20/20. He had full color vision without an APD. His anterior chamber was quiet, but he had 1+ vitreous cell. And his optic disc, he had 360 disc margin blurring with some mild hemorrhage around the disc margin. A CT had ordered by the emergency room was unremarkable. So going through everything did not seem consistent with your typical demyelinating optic neuritis. He had full color vision, full visual acuity, no APD, and then the presence of the optic disc swelling with the vitreous cell. So I know in neuro-op clinic, when we see more of these kind of inflammatory type pictures, we think about things like syphilis, sarcoid, TB, possibly Lyme disease, depending on patient's travel history and things like that. So thinking about those things, I got some additional history. On review of systems, he had a macular rash over his chest, arms, and legs for the past month. Social history, he reported having unprotected intercourse with a male partner about a year ago, and then also a history of gonorrhea 2 years ago that was treated. So we decided to wait on the MRI and get syphilis testing, which was positive. So he had a positive EIA screen, and then the RPR titer was also positive. So this patient also was admitted. He was started on his IV penicillin and then was actually discharged a couple days later after getting a PICC line, and then did follow up a few months later in the eye clinic, and his optic disc swelling had resolved, vitreitis had resolved, and his symptoms had also resolved. So another interesting case that showed up within a few days of my previous one really shows the variety of ways that syphilis can present. So that is all I had. I wanted to thank Dr. Jesse Smith and Dr. Alan Palestine for helping with this presentation. Happy to have any questions or comments.
Hey, Amit, what RPR titer is considered positive?
That's a good question. I'm actually not sure if there's a specific cut. There's two, like you'll get like a positive RPR and then also a titer. So I'm not sure. I don't know if anyone knows.
So if you have a patient with an RPR over 1 to 4, that's considered positive. Sometimes HIV patients, after they've been previously treated, so anything over like 1 to 32 is going to be pretty positive. But 1 to 128, 1 to 64, all of those titers are pretty
Okay.
rip-roaringly positive. If you have a patient, like an HIV patient, sometimes they can be treated. And if their titer dips down to like 1 to 4, but they were only treated like with maybe doxycycline or something, they may not have been completely treated and they can have persistently positive titers. And then if a patient has like a titer of like 1 to 2, that's basically been previously treated syphilis, basically, and that's not considered positive.
Yeah, I also think that that's a great point, Paula. A couple other points about syphilis. One, you can never be wrong in considering it because anybody can have it and you can cure it. Having had syphilis once doesn't keep you immunized from getting syphilis again. So towards Paula's point, if you see a patient who has a 1 to 2 titer and they have more inflammation a year later and their titers going up, they can get syphilis repeatedly. So having it once doesn't give you permanent immunity. And my last point would be on the question initially of whether this was a possible endophthalmitis, which is always good to consider in patients who have a history of drug use. It's important to remember that the concept of doing a vitreous tap in bacterial endophthalmitis that follows cataract surgery only has a 50% positivity rate. The positivity rate in fungal endophthalmitis that's endogenous is under 10%. So if you're going to treat fungal endophthalmitis and use a vitreous tap as a diagnostic indicator and it comes back negative, that really doesn't tell you that you had that you didn't have a fungus because the culture rate positivity is so low.
All right, thanks, Alan. Thanks, Paula. Thank you, Amit. Any other questions, comments before we wrap up?